I like not to take more time. So THR in ankylosed hip, as Ashish said, he does it by the Mako robot. We do it normally as you all do. So there's a little bit of learning in ankylosed hip. And these are not uncommon scenarios, even if those who are not, the patients who are not looking fused like this or trabecular continuity, they may be completely rigid. Some of them may move in the theater after anesthesia, but most of them will not move. And the problem is if you try and rotate it, it may break. So you have to be very, very careful in the patients like this. Okay, these are common scenarios. As I said, one side fused, one side looking fused, not yet fused. Okay, so these are common scenarios in our condition. So we need to be what? Mindful of what? Clinical and radiological aspect. Anesthesia and positioning. So it is very important that if you're doing in regional anesthesia, these patients are difficult to sit. So you have to plan accordingly, tell your anesthetist how you are going to anesthetize this patient. They have to plan. It's not that the fitness by hemoglobin or all those things. They have to plan how they are going to anesthetize, otherwise they'll take a hell lot of time in theater deciding what to do. That is very important. Now, exposure, neck cut, I'll deal in all these things sequentially, but definitely you have to plan, and they may need fiber optic, bronchoscope or XYZ. So plan everything in advance, because these people are very difficult to give spinal or epidurals. Okay? So ankylosing spondylitis, I'll not go into the detail, is one of the prototype of these arthritic and fused hips. Okay, the idea is to pain relief, improve the range, enhance mobility and correct the posture. Okay, but then you have to assess few things other than the hip. The hip is very obvious that patient is having painful or fixed hip. The obvious is that spine and SI joint need to be evaluated. Contralateral hips seem to be seen, and knee also need to be examined very, very carefully, because all these structures are going to affect the outcome of your surgery. Surgery per se may not be very difficult, but if the spine is involved, if spinopelvic parameters are not checked and managed, that could lead to dislocations. Okay? Remember that most of these patients, fusion happens in abduction and external rotations. Okay? Abduction, external rotation is 70% of your hips will be fused in. Pelvic obliquity, femoral canal, protusio, quality of fusion and bone quality. All these things need to be seen before the surgery. Patients like this will come to you, anesthesia as I discussed. So you can do bone scans or CT scans just to see how patient is doing, how far the fusion has happened. But these are not needed. I'll quickly move ahead, but you remember that the sacral slope plus pelvic tilt is equal to pelvic incidence. And pelvic incidence is a fixed parameter. What happens is that when an lumbar lordosis falls within 10 degrees of your pelvic tilt, okay? So this pelvic incidence. So lumbar lordosis, pelvic incidence, they are within 10 degrees of each other. If it is way beyond, you have to understand. And anteversion is one that you need to see, because it is an inclination, or you say anteversion, it need to be checked, because they change when you sit. Okay, how it happens. So what happens is when you're standing, your anteversion is less and pelvis is tilted forward. But when you sit, normally what happens, your pelvis rotates back and anteversion increases. This is just to accommodate the normal femoral head. This is normal what is happening. But if it is not changing, standing and sitting, then you have to figure out a way to manage, because if it does not, what happens in fused hip? So most of these fused hip, the picture will be like on your left. Okay, they have kyphosis in the spine. 70% patients will have kyphosis, and around 20% patient will have increased lumbar lordosis. So what happens? You have to change your inclination and version depending upon whether it is rotating, pelvis is tilted forward, or pelvis is rotated back. I'm just explaining it in very simple terms, but you need to see. Normally what will happen if the pelvis is rotating, so you can change your degrees. That's very common, 45 degrees of inclination plus 15 to 20 degrees of anteversion. That is in your normal hip. But what has happened is that if your patient is sitting and pelvis is not rotating back, then here what will happen is that if you increase the anteversion, it will dislocate anteriorly. So here you have to give less inclination and less anteversion. This will give you a stable joint. Okay? On the other hand, if it is tilting more anteriorly, then you have to increase your anteversion. Otherwise, what will happen? It will just come out posteriorly. So remember these things when you're dealing with a fused hip. Okay? So some of the patients come like this. Okay? Patients walking like this with a fused hip, and when you have done, patient will be very happy. Then the patients like this will also be there, well, protusio and ankylosis both are there. With what is happening here is that patient is having lordosis, where what you have to do is that you have to increase the version. And if you don't increase the version as we have done in both these cases, the patient will dislocate eventually. So you have to be very, very careful. Okay? Now, again, the both sides are fused. What will happen if the other side is in abduction? So if other side is in abduction, when you are positioning the patient in lateral, which most of us do, patient is in lateral and we do posterior approach. What is happening is that your inclination will change. So when you are thinking that you are giving more inclination, what will happen when the pelvis rotates back? It is much closer. Okay, while on the other hand, when it is inclination is on the other side, it will be open. When you're thinking that it is, when you're doing it on a patient, the other side is adducted. What is happening is that it will close up much more. So you have to be very, very careful when you are dealing with these patients which both sides are fused or both sides are deformed. Whether it is adducted or abducted, you have to see it before the surgery. All right. So gap, staged, I'm not going into the detail. You can do both. Anesthesia concerns I have discussed. You can do cementless total hips. That's absolutely fine. Many papers have shown that uncemented hips do equally good because these are mostly young patients that we deal with. And I do mostly posterior approach. You can very well do anterior approach or anterolateral or Harding's. That's absolutely fine with whatever you are comfortable with. Okay, but you remember that patient is in flexion, abduction, and external rotation. So when you're positioning on the table, you have to tilt the table more on the other side so that you can access the neck posteriorly. Otherwise, the patient hip externally rotated, you won't be able to see the neck at all. Okay? So see that whether you can bring in your C-arm. If you want to see the C-arm, patient is tilted and strapped properly. Okay? Exposure, removal of the head, prepare. I'll go to the video, what will happen. So your cut has to be, you may have to take a cut in situ. You have to take the cut in situ because you cannot dislocate. And you're going to take a wafer cut of your femoral head because, so this is just a small video. I'll quickly, okay, so it's not going forward, unfortunately. So what is happening, I'm taking the cut here. And this is on the other side after taking, I'm not able to scroll the video. So you have to do your reaming of the head. So you're seeing it on from the other side, and you have to start reaming your head in situ. And if you're reaming, you should ream on the inferior aspect, not on the superior aspect, because this will blow up immediately if you go up. So reaming on the inferior aspect, and you will always find a pad of fat no matter how fused it is. So remember, you can very well think about that taking a 54, 40, 48 reamer, but no, start down, 28 reamer, 38 or 39 reamer, start down. That's the key, start down. Cut in situ, take a second cut of the neck and start down reaming. And once you start down reaming, you can take help of an image. If you are very well experienced, don't do anything. You just know when you are there, okay? And then that's it. So I'll not go into the detail, I've already exceeded my time. So femoral component, usually uncemented is the choice because patients are mainly young, but you have to be very flexible. One case that I showed, we use a cemented stem as well. So hybrid is very common to be commonly used. Avoid injuring abductor, avoid crack in the proximal femur. Don't go all out going for a bigger stem to crack it. And post-op, check the stability. Combined version, impingement is very important to check in all these cases. And soft tissue tension is equally important. And if you're going to use a smaller side head, go for the dual mobility cup. That is going to give you a much better advantage. Okay, so I'll not go into just some of the cases. I'll quickly scan just last minute. So remember, for iatrogenic fracture, overeeming of acetabulum, you have to be very careful. Insufficient bone stock for the cup, component loosening, heterotrophic ossification, impingement, and vascular injury. Sometimes be very careful. Thank you.
Thank you, sir. A nice talk. A difficult topic explained so lucidly. Now, the next talk is by Dr. Amit Jaiswal.